Hello, thank you for joining this session on ethics in previous pandemics, insights from SARS and H1N1. My name is Jennifer Gibson. I'm director of the Joint Centre for Bioethics at the University of Toronto and an associate professor in the Dalla Lana School of Public Health. The conference organizers have asked me to share reflections on lessons learned from the Joint Centre for Bioethics experience with the SARS outbreak leading up to H1N1 and to identify ethically relevant similarities and differences with the current COVID pandemic. The SARS outbreak and the H1N1 pandemic were clarion calls for renewed attention to infectious disease and health systems. After decades of progress and improving health outcomes and increasing life expectancy through new health technologies, drug development, and clinical innovation, there were declining investments in public health and infection control in advanced health systems like we have in Canada. The emergence of SARS, however, revealed how unprepared health systems were to respond to a novel infectious disease and exposed an interdependency between public health and healthcare and among countries around the globe. Toronto found itself at the epicenter of the SARS outbreak in 2003. News reports of patients presenting in emergency departments with symptoms related to the severe acute respiratory syndrome, or SARS, that was not responsive to standard therapies began emerging in late December 2002 and early 2003. As scientists scrambled to identify and understand the virus, hospitals began mobilizing to protect health workers and patients from its spread. Although hospitals had infection prevention and control policies and staff, few people had experience with containing an outbreak of a virus of unknown origin and impact. The playbook for responding needed to be developed quickly. Health workers were at the front line of the response and also front line of the fear and uncertainty of what was unfolding. It was a daunting and scary time. By the end of the outbreak in Toronto, there were 44 deaths, including 3 hospital workers, around 400 suspected cases of SARS, and 25,000 Toronto residents had been quarantined. Due to travel restrictions to Toronto, the economic impact was estimated to be around $1 billion in lost tourism and retail revenues. Southeast Asian communities faced racism and social stigma. The lingering effects on hospitals, health workers, and communities continue to this day. The SARS outbreak came in 2 waves over 4 months, a short duration compared to the current COVID pandemic. For Torontonians, once it was over, life went on much as it had prior to the outbreak. However, this short episode had a profound effect on governments and health system leaders. A sense of urgency emerged to understand what went well and what went wrong, and to prepare actively and proactively for the possibility of similar outbreaks in the future. The Joint Centre for Bioethics acted quickly in the weeks and months following the second wave of the SARS to capture lessons learned about ethical issues revealed by the SARS outbreak. 5 key ethical issues were identified. Ethical issues related to quarantine. So imagine a medical clerk is asked by public health officials to remain at home in quarantine for 10 days because of possible exposure to SARS. She wants to comply, but fears that could cost her her job and her apartment. A second ethical issue pertained to privacy of personal health information and the public's need to know. For example, in this case, we might imagine a nurse at a hospital affected by SARS feels unwell and has a fever. After weighing the risk of having the disease against losing income and placing a burden of extra work on her colleagues, the nurse takes a commuter train to work. She's later found to have SARS. Medical officials choose not to name the nurse, but use the media to warn people who may have been on the train with her. A third issue pertained to duty to care. And in this case, an intensive care nurse, we might imagine, is afraid of contracting SARS at work and infecting her spouse and children at home. She's torn between the potential danger posed to her family and her professional duties. The fourth issue that was identified was related to collateral damage on patients who, for example, whose surgeries may have been postponed during the SARS outbreak. And finally, the fifth issue that was flagged was a recognition that SARS was emerging in a globalized world with interdependencies across and between institutions, systems, and countries. All of these issues continue to be relevant in the COVID-19 pandemic. This early work on SARS, though, served as the basis for the development of an ethical framework for pandemic influenza preparedness. The Stand on Guard for Thee report, with which some of you may be familiar, was influential on pandemic influenza plans in the following years leading up to the H1N1 pandemic in Canada and abroad, and was also included in business continuity plans of some large corporations. The ethical framework outlined 10 substantive values and 5 procedural values, which are outlined on the screen. These have stood the test of time and continue to be relevant today in the COVID-19 pandemic. Through the work in developing the Stand on Guard for Thee report, additional ethical issues emerged and sharpened our focus around where preparedness planning ought to go. It highlighted issues related to priority setting, whether that be to access to the intensive care unit, to antivirals, to vaccines, or other supplies. It flagged issues related to visitor restrictions, to contact tracing, to the deployment of health human resources and staffing and their needs, to resource sharing and system collaboration, and the importance of stakeholder engagement and public communications. Again, many of these issues resonate today in the COVID-19 pandemic. The SARS outbreak and the subsequent planning for pandemic influenza led to significant innovation in bioethics thinking and practice. Whereas there had been and continues to be a robust field of scholarship on clinical and organizational ethics within healthcare settings, and a correspondingly robust area of scholarship on public health ethics, thinking forward into the possibility of a pandemic in the years leading up to H1N1 underlined for us the need for an integrated ethics approach, drawing on both healthcare ethics and public health ethics, what we might call pandemic ethics. So at this point, I'd like to shift over to reflecting now on where we are in relation to COVID, the COVID-19 pandemic, and where we sit in relation to the ethical issues and challenges we may be facing. It's been very interesting to be participating in Ontario's COVID pandemic response. For the first time, in my experience over the last 15 or so years in the field of pandemic ethics, there has been an unprecedented role of bioethics and bioethicists in pandemic preparedness and response, locally within public health units and health institutions, provincially. For example, we think of Quebec and Ontario as two examples that has built bioethics in from the get-go at the highest levels of decision-making within the health system, and internationally, where the World Health Organization has struck and has a very active COVID ethics working group. In Ontario, bioethics experts have been engaged at all levels of the health system response, from the command table, where I sit as an advisor, to the Ontario Health System response structures, including at institutional and regional levels, in public health units, within health institutions. And this builds on the legacy of pandemic ethics work over the last 15 years, and it speaks to the legacy of our collective work in Canada in this area across the country. However, notwithstanding this legacy of work, there's nothing like the real thing to reveal the extent and depth of ethical considerations of a pandemic, particularly one that necessarily reaches beyond the traditional boundaries of the health system into the day-to-day lives of all of us. Although the bioethics field had some insight to build from, it has, like everyone else, been learning through the pandemic, or as I've often heard said, flying the plane while building it. Whereas our first experiences planning forward into the possibility of a pandemic flu sharpened thinking around pandemic ethics, I think what is becoming increasingly revealed is that there is an emerging area of health system ethics which reaches even further beyond the healthcare system, beyond public health systems, into some of the elements which define the social determinants of health. So we might think of this as ethics in health systems. Increasingly, I'm hearing health workers and health institutional leaders talking about all patients are our patients. All patients and residents of long-term care facilities, we're accountable for all of them. And to them, we owe accountability in terms, for example, of patient transfers between acute and long-term care, and also recognizing that there needs to be solidarity and collaboration amongst institutions to ensure least negative impact on the most vulnerable populations that are being served. But the COVID-19 pandemic has also signaled the need for thinking about the ethics of health systems. And indeed, we've learned, I think, across the country, the ways in which not all patients are treated equally. Many of them face structural barriers to access, which predated the COVID-19 pandemic. Many of them face social and systemic vulnerabilities. That some face racism in their day-to-day lives and also within health systems. And others struggle to find a way to have their needs met or those of their loved ones, but face discrimination. Not all patients are equal, but ought they to be. And this is the call of ethics of health systems in order to respond. We might think that three of the core values that I see emerging in particular in relation to health system ethics is a call to dig deeply into and to think carefully about proportionality. An action taken in one element of the health system will have an effect elsewhere. And so that attunement to the upstream and the downstream elements calls for us to bring thoughtfulness to what those downstream effects might be, and correspondingly, what upstream implications there may be of actions taken downstream. There's a call within a health system ethics lens to think more about solidarity, to really reach across the table, across different actors and institutions that normally would not be collaborating to this extent, and to demonstrate solidarity to the most vulnerable within the health system, which may include personal support workers and others who may be providing valuable care, especially for our aging populations, but are not correspondingly valued to the extent that they should be. And then accountability. And this is raising interesting questions now about to whom we are accountable. Is it to the system itself, or is it to the citizens and the communities that are being served? And what would it mean to better engage those who are most affected in the response, in the planning and the response and the resilience and the recovery which follows, in order to be able to establish more robust understandings and relationships of accountability? But COVID-19 is a wicked problem. It's not simply complex. It is wicked in the sense that there's no option not to act, but there's no clear right action often. This is a challenge for decision makers, but it's also been a challenge for us working in the ethics field. Balancing all of these competing elements within the COVID response, whether that's evolving data, competing values, an evolving political and economic environment, multiple stakeholder interests, all of which have a call on being heard, and yet these may not be compatible. Patient and population needs, which may be divergent, and local and health system priorities, which often work together, but the local material differences may mean that some system priorities need to be translated in different ways locally. And again, without a playbook, be able to do this, there's a lot of flying the plane while building it. So in some ways, what we might do is to think about how we might learn from other areas of ethics to be able to draw some insight how we respond. In many ways, COVID-19 is a form of social innovation. We are learning as we go. We're learning as we go with a core intent to save as many lives as possible, as ethically as possible. So in addition to the need for a clear articulation of ethical principles, we've been learning along the way that we also need to have adaptive, inclusive, and iterative processes, lessons that have been learned from the field of science and technology studies and the introduction and development of new technologies. So as we do things differently, we must do things with each other differently. We must be with each other differently in order to be able to respond appropriately. One of the key lessons that I've learned along the way here too is the human face of this work. It is not simply a matter of plans. It's not simply a matter of resources. It's not simply a matter of finding a technical fix to a very complex problem. Indeed, this is a human problem, one which is calling on each of us, whether as citizens, as bioethicists, as actors within the health system response, as frontline providers caring for patients. We are being called to a level of resilience that we've never experienced before. This is to bring the human face into the work that we do. In many ways, the COVID-19 response has underlined the extent to which we can come together as a community to respond together to big challenges like this. And yet at the same time, we know that there is increasing incidence of mental health issues across the country. We do know also that there are upticks and deaths associated with the opioid crisis. And in fact, we are facing multiple pandemics concurrently at the same time. And so for bioethics, a call for us is to begin thinking again about what it means to experience moral distress in such situations and to play our part in serving to meet the needs of those who are providing a response, to avoid and to prevent moral injury as a result of this. And this is something that we learned in the SARS outbreak. Many of the clinical staff who were involved in the response at that time carried moral residue with them into planning for H1N1. So these are long-lasting effects that we, in our thinking about resilience, we need to be thinking about not just economic resilience, but the human resilience, which speaks to the moral heart of what we do within health systems. Finally, the other more compelling, perhaps, lesson that we've seen revealed to us is the extent and the breadth of health and social inequities that already exist within our provinces and territories. Just very recently, Dr. Theresa Tam, Canada's Chief Public Health Officer, released a report reflecting back on lessons learned from Wave 1. That it revealed a primary focus on equity should come as no surprise. The COVID-19 pandemic has affected Canadians differently and in different ways. It's such that some are now perhaps more vulnerable than they were before. What might we do together in order to be able to mitigate those effects as we think forward into Wave 2, as we move forward into recovery eventually? How might we find coming out of this examples of resilience, examples of community social justice that we can build from, that we can learn from, so that what may come out of this is a country and communities and health institutions and professions that feel that they together are moving forward in a way that allows them to not only be able to meet needs, but to fulfill a call to justice and a social justice in so doing. COVID-19 is a broad, multi-layered health system challenge. We know this. And it's operating on an unprecedented scale, on a timeline that is uncertain, and it's operating at the intersection of our healthcare, social care, public health, and broader community systems. As we look forward into where we must go next, the call of thinking about these issues from a systems perspective is a challenge in itself. And yet at the same time, it is precisely that challenge that creates the space for us to be able to come together to care for each other. Given the novelty of COVID-19, we must act under conditions of uncertainty. And because of that uncertainty, we are called into social innovation in ways that feel unfamiliar and may lead us to feel even greater uncertainty about whether or not we're doing the right thing. Nevertheless, this is where we can draw on the insight of those who have experience in living COVID-19. That is all of us now. For us to be able to draw from what we've learned in order to be able to bring ethical principles into practice, given the insight and the wisdom of experience and the relations that we've built along the way. This is a challenging time for us. It is also a time when we may be able to find our path as Canadians towards a more just Canada. Thank you for your attention. Be well, stay safe, stick together.